Jacob, what made you choose to become a psychotherapist, and why did you then change to voice and osteopathy?
I was always interested in the relationship between the body and the mind. I was very influenced by Maimonides' thinking already when I was in high school. And then when I did my osteopathic training, which is concentrating or focusing on the body, I felt that there is a big part missing. And then I went to do psychology because my main interest really is psychosomatic presentations and chronic pain, which I regard as a form of communication. And I really needed to understand more about the psychological side so I can treat the whole patient in the full sense of the word.
What are the most frequent complaints of your patients?
It looks as if it's a straightforward question, but it's quite complicated because many patients come and they cannot describe the complaint. So sometimes it takes time to understand what are the symptoms. But common symptoms from the musculoskeletal system are pain, discomfort, stiffness, loss of range, loss of vocal stamina, lack of clarity in the voice, swallowing difficulties, all sorts of sensation of tension in the throat, neck aches, difficulty breathing.
What do you specifically ask all of your patients, other than usual history taking? And which aspects of osteopathy do you want them to understand before starting your osteopathic interventions?
Well, musculoskeletal symptoms normally come from the way we use our bodies. So I really would like to know how much of understanding the patient has with regard to his own contribution to the problem. So, for instance, it would be important for me to find out whether the patient really understands the symptoms and whether they have any idea what causing the symptoms. Normally this will be my open question. The way people answer that question gives me a lot of information. Now, with regard to what patients expect, it's rather complicated because people may find a lot of information on the internet. They will hear all sorts of reports and feedback from their colleagues, friends. Of course, that by itself becomes an issue because they expect a so-called a cure or a quick fix, which is never the case when it comes to musculoskeletal problem. So I would explain to them the limitation of a treatment. I will explain to them what to expect, and while I'm examining them and while I'm treating them, and I always tell them that they are in control, they can stop me anytime, and I will also warn them about some outcome and side effects of a possible treatment.
How about the circumstances of onset?
That's the most important point in my history taking, because if I understand the circumstances of the onset, I will have a much better diagnosis and prognosis. If I have a patient who is unable to give me the circumstances of the onset and we can't work it out, I feel quite limited in my approach.
So which aspects of past medical history are most important for you?
Total loss of voice in the past, because total loss of voice can give me some ideas about susceptibility to viral infection that might respond spontaneously, and it can point to a psychogenic voice loss. It can point to a trauma which now the patient is suffering from a post-trauma because of that. Past history can also tell me if there was a period of depression and so on. So that's quite important. Past accidents, because I think post-trauma is something that is underdiagnosed. So really I would like to have some clues from the past as to the possibility that what the patient presents in the here and now is a post-traumatic issue.
So, is there a timeline for the organic symptoms versus a timeline for emotional or psychosomatic problems? Is that always going one-to-one associated, or is that different for you?
It's an interesting question. If it was just physiological, let's say hard-working larynx, it can develop over years, and maybe then psychological circumstances might speed up the onset of the symptom. That doesn't mean that there wasn't a problem waiting to happen. The trigger is psychological, then it might be quite immediate and maybe matter of months since what I would call a psychological injury.
How about personality markers? Is there a difference between the patients because of their personality and what happens to them?
Of course, we have to remember that a patient might have, let's say, mild symptoms and nobody would know and they will carry on with life. And the same level of symptoms will bring the patient into the clinic to complain about and to seek help. So, of course, we have to remember that a patient who comes to the clinic is already telling you something about their need to understand maybe what's troubled them, or maybe they have a real issue that interferes with their work or inner comfort. But somebody else might not complain about the symptom, although they suffer. So yes.
So how about, let's say, two examples, narcissistic people or obsessive compulsive disordered people. Can you tell us a little bit about that?
Yes. Let's say if you have a narcissistic personality organization, you may be very, very sensitive, let's say, to the fact that a conductor didn't greet you in the morning, and that by itself may be a cause to complain about something which is wrong. Quite a gross injury. And another person who is not as sensitive might ignore that and might understand that maybe it's nothing to do with them. So obsessive compulsive, they might be over-focusing on a symptom, and they will be concerned about what might cause a mild pain. And they will go on and on in order to understand. And then, of course, the level of pain or discomfort will be amplified just because of that focus, rather than to get on with it and to ignore it. So that's two good examples.
So you try to find out in your history taking what kind of personality they are. So we had the narcissistic, the OCD. Is there anything else that you might want to
Of course,
mention?
I mean, a patient who has a tendency for depression, manic depressive, although we don't need to go into labeling a patient, but I think at the ad hoc, if you really want to understand who the patient is, it's nice to know psychological pattern in their personality, although that's the personality and we have to deal with what comes. But I'm not going to send them to a psychiatrist because that's completely irrelevant to the symptom.
So how about, if we're talking about history taking, let's say in cases of previous neck larynx trauma problems with the back of the neck region, how much would that interfere with your therapy?
Okay, because many people make unnecessary links. And I'll give you an example. Let's say that you woke up in the morning with acute neck ache. You are in discomfort. Of course it will affect your state of mind. Of course it will affect your comfort, and that's why your voice will be affected. That doesn't necessarily mean that there is a physiological connection there. But the patient in their mind, when they are in discomfort, the voice will reflect on it. So it doesn't mean that your larynx is damaged because you had a neck ache. But many people do make unphysiological links in their mind. There is a lot of, unnecessary connections, but people believe they are. For me, the only reason why I will be concerned with the neck is for safety. Because if somebody had a neck injury in the past, I need to know that, to know how to approach them while I treat them. But that's not necessarily part of my treating the voice per se.
So tell us, in a routine diagnostic day, how much time do you have for history taking before you actually touch the patient?
So my first session normally will take about 45 minutes, given that there are no language difficulties. 15 minutes will be more or less for history taking, and then the examination will take me about 5 minutes while the patient is standing. In my own private practice, I have a plinth, so I prefer to treat the patient lying. In the hospital, I will only have a chair, so I will treat them sitting. And interestingly enough, sometimes some techniques are easier to perform sitting than lying. But I would rather have the patient lying because I can then relax them. And if I have, let's say, 25 minutes for the treatment itself, maybe 20 minutes or 15 minutes will be spent on relaxation until I'm happy that the patient can receive the manual therapy specifically to the larynx and to the breathing apparatus. And the treatment itself on the larynx and the breathing is about 10 minutes.
Well, patients come to you because they want to see you as an osteopath. I don't know if all of your patients also know that you're a psychotherapist.
Mm-hmm.
So, and now if you have history taking like 15 minutes, do some patients say, hey, listen, I came here to get my neck treated, my muscles treated, and then you really go into the history? How does that relate?
Well, in fact, when I take history, there are always open questions, and I don't ask a single psychological question, except maybe one in the medical side. I always will ask a patient if they ever had antidepressant in their life, because that will tell me more or less maybe what patient does when they feel low. It's not a psychological question. We'll never ask a direct question, tell me about your father and mother and things like that. It will come up in the history taking, or maybe not. Mm-hmm. It's not as important. I will try to find out about nervous patterns. For instance, I will have every system in the body, I will ask, let's say, about irritable bowel. A medical question, it's not a psychological question. And things like that. So I understand more or less what are the psychological strategies, or whether the patient has a tendency for psychosomatic symptoms, but never a psychological question as such.
Okay. Now let's get to the exam and the findings. So how do you do your diagnostic manual examination? So you said that you do it patient lying down or sometimes sitting, and do you instantly combine it with a therapy, or is this something like first you do diagnostics and then afterwards you do a therapy?
First of all, the examination itself, as mentioned before, is in standing, and the first thing nowadays I check is breathing patterns, in particular the exhale, how much of breathing out the patient has, because this is the relevant thing for voice production. I'll check the pliability of the rib cage, and to see whether the rib cage has a tendency to get rigid in inhalation, meaning that the sternum is more parallel to the floor than vertical. And I will check pliability, and then of course I will do the Lieberman protocol from the jaw all the way to the sternum to check the musculature dynamically, statically, and that process will take about 5 minutes. And at the same, I already begin a little bit of the therapy just for the breathing, because I would like to see whether the patient can relate to shifting concentration from upper chest breathing to move more the diaphragm. And then I carry on when the patient is lying. So a little bit of diagnostic treatment starts while I'm examining.
For people who like to follow your steps and want to do your protocol, would you rather recommend them having the patient lying down or sitting? Because in the ENT practice, let's say most patients are sitting, but would you recommend, get yourself a plinth and then have your patient lying down?
I think it's more a preference of the therapist. You have one more degree of freedom when the patient is lying. You have the two hands that can do techniques. When the patient is sitting, you have to stabilize the head and the torso, so one hand is occupied with that, and then you really have to clear about one hand technique, because the whole idea here is to be specific. So if you really want to anchor, to stabilize, let's say, the hyoid, and you want to stretch the thyroid away, it's easier to do it when you have two hands ready. And the patient is sitting, you have to learn how to do it with one hand. It's possible, but it requires a bit more skills. So maybe for a beginner, it will be easier if the patient is lying.
So I think this is a very important point, and I saw you a couple of times when you really spent many minutes on relaxation before you actually did something. So, and can you tell us one or two tricks how you relax your patient? Let's say they're lying on their back on a plinth, and how do you relax them? Is there a quick relaxation technique?
Well, not really. First of all, let me explain to you why I need the patient relaxed, because unlike CBT or cognitive behavior changing habits, I need the patient completely passive, so I can stretch the muscles pure and simple. If the patient resists me or helps me, it means that they are kicking muscles into action, and that's interfering with what I would call specific passive stretching. That's why I need the patient completely relaxed. Unlike behavior therapy, where you need the participation of the patient. Now, it's not that easy to let go, as it were. I will try to do some relaxation technique by relaxing the suboccipital muscles, which have a massive input, neurological input, sensory input to the brain. Try to coordinate the patient breathing and really use metaphors to let the patient relax. Some will do it very quickly, and some might resist throughout, and then I have no option but carry on working, but then it's less favorable. And in terms of prognosis, a non-relaxed patient has a less better prognosis than a relaxed patient.
So I think this is a very important point, because when we see patients, isn't it that many patients have problems with their neck muscles in the back?
Yeah.
But how is that related to the anterior muscles, the paralaryngeal muscles? Is that a tight association, or is that rather loose? And can you tell?
I think here the link is the position of the head. If the position of the head is not in the midline, but the patient has a tendency to thrust the head forward, then of course there will be a relationship, because the more forward the head, extensor muscles work harder to bring the head against gravity. If the head is very balanced, only the suboccipital muscles are working. The more forward the head, the more tension in the neck, and also the paralaryngeal muscles anteriorly will be on stretch. So really the aim here is just to bring the head as backwards as possible without compromising anything else in the spine, because people will shift the need to bring the head backwards into hyperextension in the lumbar spine, and that should not happen. So, and that's a bit tricky.
But people can have, let's say, just anterior neck problems with the larynx without back of the neck problems, and vice versa?
Yes, of course.
How can you tell that the patient is relaxed enough for the next steps of your examination? How do you find that out? Palpate that or see that?
No, first of all, I'm looking for vegetative signs. Very often, a changeover between the sympathetic system and parasympathetic. So you really hear abdominal rumble, meaning that the patient is now relaxed and moved from sympathetic to parasympathetic state. And you can hear the abdominal rumbles. You can also feel how the head begins to be heavy under your hands. I check to move the head into slide rotation, and I might feel that the patient is not helping me anymore, which is a good thing. These are little signs. You listen to the body, you listen to the breathing, you see the legs relaxing, then you know.
But let's say a patient is lying on a plinth, you don't know the patient, you don't ask the patient, and I would ask you, please palpate all the muscles and around the larynx, the anterior muscles. How is that? Can you tell by just palpating all the muscles a story about if they're chronically stressed, if they're strained, if they're very much relaxed? Is there something like a normal status of all muscles? And yeah, how much can you feel, and how much is it what you already know about the patient?
Well, palpation has two states, passive and dynamic. If, let's say, I approach the laryngeal muscles, passively, I find patterns of tension, like, for instance, there is no space between the hyoid and the thyroid. The the larynx is very backed, meaning that I can't go behind it, one side or both sides. If I feel the floor of the mouth very, very tight, if I try to move the larynx from side to side, or the hyoid or the thyroid, nothing happens. The gap between the cricoid and the thyroid is minimal, meaning that the vocal folds are stretched. So these are findings of hyperfunction. And then, of course, I will introduce the dynamic stage. In the passive stage, I could detect tension patterns, not knowing whether it's just hard-working larynx or a psychological one. Now, if the patient responds in a certain way to my palpation, the passive palpation, I can conclude maybe there is a psychological issue. For instance, if I touch a larynx and I will feel a retreat, then I know that there is an element of fear or anxiety or sensitivity to touch. But if there is no reaction from the patient and they're completely zero in movement, then I can only tell you it's a tight larynx or it's a relaxed larynx. Then I will introduce the dynamic thing. And if I do, let's say, a yawn or a swallow, and if suddenly I feel that the whole larynx relaxes, I know that there is a holding pattern, which I think is an emotional one, either fear or anticipation or excitement, whatever. So if the patient yawns where there is a zero tension, then the reaction to the yawn or the sigh or the swallow will tell me a lot about how dynamic this tension is. And that can reveal a little bit about state of mind. Now, if the larynx doesn't relax with a yawn or sigh or a swallowing, then I know it's called a hard-working one. So you can learn a lot just from that.
So let's say, just for instance, if you have a non-rotatable or back larynx, you cannot say that it's always pathologic. All you can say that there is something that induces that.
Yes.
But it need not be pathologic. It could be in a healthy person. Is that
absolutely
right?
In fact, I don't use pathology in the way medics using it, because for medics, pathology means that there is a pathological process. For us, it's more of a function. So it's either a lack of function or a function that disables another function, if you see what I mean. So it's not pathological. And yes, there are many holding patterns. Now, when it's pathological, let's say if you have unilateral paresis, you will have what medics will call also a rotation that goes with the paralysis. So that's related to pathology, but it's not necessarily a pathological thing in the way I think about it.
Do you always follow your strict protocol when you're doing your manual examination, or do you go straight to the, let's say, region of interest?
No, I always use the protocol because it's just second habit. And
so how long does that take, your
2
protocol?
minutes.
2 minutes from all the muscles?
Yes.
And static and dynamic?
Yes.
Wow, that's pretty quick, isn't that?
Based really on memory. I'm sure that if I relate it to your work, I'm sure that when you started doing phonosurgery, it took you 3 times as long as what you do now. And I see you doing now things which I can't imagine many surgeons will do. And that's really to do with dexterity that comes with time.
Let's go into some specifics of, let's say, daily complaints. Say, many clients, they may think that there's a correct or good height level of the larynx, and especially in singers, and sometimes they complain and say, well, you know, my larynx is too high or too low. Is there something like a high larynx or a low larynx?
Of course there is. If you are a physical therapist, you know that they always use a little bit too much. The shoulders are never in a completely relaxed position, and likewise the larynx. Now, if you're, let's say, a soprano and you live high and you never do warming down, the larynx in time will stay high. When I talk about high larynx, I don't like to talk about it in general terms, high larynx. It doesn't mean much physiologically, but I would like to talk about the height of the hyoid. I would like to talk about the quality of the floor of the mouth. There are all mechanisms that involved in lifting the larynx. I would like to talk about the thyrohyoid mechanism. I would like to see what the pitch mechanism is doing, or the frequency, which is the cricothyroid joint. That by itself can tell me if the vocal folds are on the straight side, which goes with high larynx frequency. I believe that the lowest position of the larynx, not pushing the larynx down, but letting the larynx drop with gravity to bring it to physiological level, that is the most relaxed larynx. And I think that it makes sense that with gravity it will be the lowest position without forcing it to a low position. Just let it sink down with gravity. But nobody is there. And how do I know that? Because every larynx can be manipulated and stretched and relaxed to a lower position, and I can lower at least 10 hertz in every larynx that I manipulate, if it's healthy and there are no complaints. Likewise, I can drop the shoulder by a centimeter on everyone.
So let's take another big field. Many patients come to you with a globus feeling. And let's take the patients where everything else, every organic other reason is ruled out, but they still may feel that constant lump in their throat, and mostly, say, at the level of the larynx. Is there a specific globus muscle?
I don't think so. Pain in the throat is not localized because of the complicated neurology there, and there is pain referred. People will always feel the globus maybe at the area of the thoracic inlet, because simply, mechanically, it's the most narrowing part of the spine, and also where the lordosis is great. So everything it's like a traffic jam there. So of course, everybody will feel a bit of tension there. But I find that with globus it can be any part of the pharynx that will do it, or even floor of mouth which is tight, or back larynx in general. So that's the first issue. Now, with regard to excluding all the organic pathologies, patients sometimes do not believe that the doctors really excluded it. They're pretty intelligent, and they say, yes, the doctor examined me to the level of the glottis, but I feel the tension underneath, and the doctor didn't see that. So although they are embarrassed to tell the doctor, sometimes when you show the patient that there is nothing there, they simply do not believe it because the symptom is very strong. So that's an issue of belief. So that's one aspect of globus. Now, in my experience, globus is psychosomatic. If I take the time to understand the circumstances of the onset, there will always come a psychological reason to the circumstances. Now, a feature of globus, which is not very much talked about, is throat clearing. They normally go together, and of course the throat clearing creates a very irritable larynx, which emphasizes the globus symptoms. And so when you deal with globus patient, you need to understand the circumstances or the psychology behind it, and the treatment alleviate the feeling of globus, which takes some of the anxiety away, but you also have to deal with the irritable chronic throat clearing. Otherwise, you cannot be successful.
So what does the globus per se do? Does it react on the muscle or on, let's say, the inner lining of the mucosa?
I think it's to do with chronic muscle. Start with some holding pattern and muscle contraction. And then, of course, it interferes with physiology. Then the irritation brings a chronic cough. Or it's the other way around. Let's say if you had a period of of chest infection with a long period of dry cough, you create irritability, and then you carry on throat clearing, and then it becomes the entity of globus.
So which muscles are that?
I think it's every part of the pharynx, but also other muscles, because muscles don't contract in the throat in isolation. They always work in synergy. So it's the whole thing goes in flame, really.
So can we say that these muscles are also emotional muscles?
Oh yes, I will tell you a joke now, but I would not allow you to laugh. And you tell me where you feel the sensation. And here you have a very nice self-illicit globus sensation.
So that means if we have a globus patient, we should always think about a possible or the possible psychological start, reason, and does it play a role when there was the onset of the globus?
Oh yes, just the other day. Psychological mechanism of identification. So let's say if a family member died of laryngeal cancer, sometimes a patient will develop a globus. And when I ask history, and they say, oh, it started when my father died, and how did your father die? He lost his voice and he had a globus. But we had a patient, and I asked him what were the circumstances. He was angry with me that I was asking normal medical history and said, look, I came to you because I only have a globus, nothing else. Nothing came up, and I asked him, is there any family members that had maybe laryngeal cancer? No one in the family had any voice issues. That was categorically stated. We finished, and I didn't have any clue. And if I don't have any clue, I know that the prognosis will be bad. You've already been to many other clinics with the globus, and said, what can I offer now? So I said to him, maybe you try to explain to me why you have the globus. What is your thinking? Suddenly he came up with the fact that he was a bit OCD. He liked to wash his hands. And we were talking, and suddenly he said, oh my God, my father had a stroke. He developed aphasia for 4 weeks, and he lost his voice. And while we were telling the history, it didn't occur to him. Now, as a psychotherapist, you understand sometimes the need for denial mechanisms. So really, he obliterated the fact that a family member had a similar issue of voice problems associated with severe illness that brought to death. Once we understood that, the symptoms disappeared basically. And then of course I did a little bit of manual therapy just to reinforce that. That was the end of the story. This is the difference between approaching globus as just a symptom, because if you don't understand the underlying issues, it will carry on. So that's quite important.
Questions related to treatments. Let's say in a given patient who is relaxed after 5 minutes and lying comfortably on the plinth, what do you examine first? You said you always go according to your protocol. Where do you start?
As a routine, I will stretch the neck and try to reduce lordosis. In particular, if it's an anterior neck, I will do a little bit of relaxation for the thoracic spine. So there will be some flexibility, and the patient will be able to accommodate a slightly different head position, which always should go backwards. That's the first part. And also it's very nice for the patient if you start with the big muscles of the neck just for relaxation. And I call it to make friends with the tissue. And then I will go to deal with the jaw. I will try to check for jaw tension and release it. The jaw is of course the basis for where the larynx lies. And then I will go to the floor of the mouth, which is a very easy area and also not that pain sensitive. So I can do a lot of stretching there, and then I will move to the suprahyoid muscles if I can approach it. Sometimes if the hyoid is very high and I can't go into the base of the tongue, I will have to prepare this area. So I will go to relax the thyrohyoid mechanism. I will stretch the whole larynx down until I'm able to go into the base of tongue, which is a very common complaint by singers. I will check the middle constrictor, which is also used by singer as a secondary resonating chamber. I will try to go into the arytenoids if there is a call for it, if there is asymmetry, if it's a bit of a phase difference or difference in closing, or let's say with arytenoid granuloma, I would like to relax the tension there. I will go to the cricothyroid joint to relax the vocal folds. I will stretch the inferior strap muscles just to allow more freedom in movement, and I will work a little bit on the breathing, in particular to make the rib cage a bit more flexible and to activate the diaphragm a bit more.
Would you recommend for everybody who's running through your protocol also to touch the arytenoids and to get to the back of the larynx? Is that a standard for the beginner or is that for the advanced?
It's definitely not a standard for beginner and definitely not even for advanced. The arytenoid is, I think it's quite a useful area to treat, but we don't have enough knowledge. And you really need to know your anatomy and very good palpatory skills because you don't really want to overstretch the recurrent laryngeal nerve, in particular when you rotate the larynx.
But otherwise, would you say, according to your protocol, is that a safe thing? Is there anything that the beginner should look at and to avoid? In your courses, you always say, well, you have to avoid this and that.
Safety, yeah. Well, as long as you don't get near the carotid body and the big vessels in the back, you are safe. The only technique that I do not recommend, that part of our knowledge, is to touch the arytenoids.
Did you ever have any complications?
No, but I had a patient who decided that he really liked what I did to him at the level of the arytenoid. A week later, he did something and he probably overstretched the recurrent laryngeal and he called me with no voice. You learn. You learn from other people's mistake. Now, with regard to what I'm saying about the arytenoid, I think manipulation or laryngeal manipulation is an extremely safe treatment, but it requires knowledge, like anything else. I mean, in the hands of a surgeon, a good surgeon, the risks are less than a beginner. And in particular with the arytenoid, because it requires a lot of palpatory skills, and you have to go pretty deep in order to rotate the larynx together. Safety is paramount, really, in our work.
How about the need to be very specific in targeting an anatomical structure?
Well, that's quite an important osteopathic principle. We really like to target the tissue that is causing the symptoms in order to be specific. And of course, once you know what is the tissue that is causing the symptoms, you can design a treatment plan, which is specific, and that's why it's so fast and it's so effective, which is a big difference to non-specific massage, which you do something, you don't have a diagnostic process, you don't have a treatment plan, and you don't really know what you really want to achieve. With osteopathy or with specific idea of the tissue that you really want to treat, you want to end up stretching, relaxing a muscle to its initial resting length. So it's a very, very specific target. And if it's a joint, you want to identify stiffness and to mobilize the joint until it restores full range of movement. So it's very clear what you want to achieve, rather than just to say, oh, I do non-specific something.
So you definitely do not do a massage to the patients, because some patients came to us and say, well, I want that massage. It's not a massage. And on the other hand, does it hurt when you treat your patient?
First of all, to be honest with you, I don't know what massage is. I know what manual therapy wants to achieve. Massage, to my mind, is something that people do on the tissue, and really it feels nice and relaxing and it's fun. But it's not therapeutic in the way we think about it.
How about, let's say you do your treatment, patient is relaxed. Do you actually speak? And do you explain something, what you do, or do you have a quiet environment?
Well, it's really much more to do with my communication with the patient. I do not speak if I don't see a need in the patient to know, and if they are completely relaxed. When I go to a painful area, I will say, look, I appreciate that might be a bit more painful. If you want it to stop, you should tell me. And if a patient asks me what do you want to achieve, I explain what I find there and then. So it's basically, I respond to the patient needs. And if I know that I'm about to do something that might be frightening for them or painful, I will give them a little bit of advance warning.
So I assume that high-pitched voice is quite frequent among your patients. And can you tell us about your findings in those clients?
Well, the larynx is a dynamic musical instrument unlike any other. When we go down in pitch, we lower its position, we relax the vocal folds, and when we go high, we require muscle action. We require the larynx to rise, and there are many, many muscles who lift the larynx up. Of course, the cricothyroid joint will close to stretch the vocal folds in order to increase the frequency. So high larynx has a very clear presentation, a higher muscle tension and a closed cricothyroid joint. A lot of the factors that determine the position of the larynx is habitual pitch. And let's say if we have 2 octaves, we are non-trained singer, where is our habitual pitch? Should it be on the top part or should it be the bottom part? And many people keep high-pitched voice not knowing, using too much energy. If they then become professional voice users, this extra voice load tires the system very, very quickly. So I believe that the voice should be bottom in octave and relaxed and supported.
How much is your success based on, let's say, psychology, placebo, the magic touch of your hands? People know that you're very famous for what you're doing. And is there any guru effect during your work?
All of the above. The only thing that I really don't like is the guru issue and my fame, because that doesn't help the patient. And in fact, if patient came to me and they say, we heard so many good things of you, that's the first thing that I will challenge. And I said, look, that may be right, but we have no knowledge what your problem is, and maybe it's not related to any other success stories. Unlike medicine, I would love to encourage placebo effect, because placebo, in my understanding, is the healing process of the body. I mean, the placebo issue is the enemy of pharmaceutical companies, because they really want to show that medications are more powerful than the so-called placebo effect. But for me, if there is a placebo effect, it's a good thing, because that's how the patients heal. In fact, there are fantastic research now on placebo in medicine, find fascinating results, that patients heal much better with a better placebo effect. That's effect. So placebo for me is not a curse, it's a good thing, and I would like to encourage placebo. And of course, the manual therapy itself is very specific and very targeted. So all of the above, as I said before.
So if you have a very specific targeted treatment, does that mean that if the patient does not have an immediate response to whatever you do, that there will be no late effect, let's say hours or days later? Or how is that? And what do you tell your patients?
It's an interesting question. If I do a specific treatment, for instance, I managed to lower the larynx centimeter. This effect should impact on swallowing, for instance. So if the patient is aware to what I done to them, but they say, oh, the larynx travels more, or the larynx goes up, or it feels like an open hole, or I don't feel the tension. If a patient says, I feel no difference, it's a bad prognosis. It means that there is something problematic with the kinesthetic perception of what's going on, and the patient maybe is in a state of dissociation from the body. So that really tells you a lot about the prognosis. Sometimes, if the patient does feel the difference, and I said, maybe you don't need to see me anymore, they are a bit concerned. Is that all? Because they think that only one session is not enough. And they said, if you really want, you can come to me for a second session. And sometimes the relaxation carries on. So I saw patients who said, look, I felt much better, and then it got better in time. And I want to say something about the time element of a symptom. Let's say that you have a globus, and it goes for months or maybe more than a year. So the time element, the symptom itself begins to inflate itself, makes the patient more anxious, and then you come to me, and I say, if we are lucky, we will fix it in one session. The patient does not believe that a problem that is so, in his mind, so persistent will disappear. So in fact, the time element is a problem for me because I do believe, and I have the clinical feedback, that yes, you can get rid of a globus in one session. But because it lasted so long, the patient doesn't believe. He said, what? In one session? In 5 minutes? It's embarrassing, but yes, that's the answer. But the patient cannot believe that, because how come that such a big symptom is so easy to get rid of? And nowadays, when I understood that issue, I explained to them that the fact that they had the symptoms for such a long time, not because of the size of the problem, but the fact that it wasn't diagnosed. And there is a big confusion here, and I think doctors should be aware that the length of a symptom that is not diagnosed by itself is a problem.
But didn't you say just previously that the globus is a psychological problem?
It is.
So how's that related to your 5-minute approach of?
Because if I understand the circumstances, the patient of course understands the circumstances. They understand why it was not diagnosed before. They understand that they made a link, unconscious link. And that's of course immediately takes the problem away.
Does that also mean that, let's say you talk to the patient understands the psychological stimulus causing the globus, that you even do not have to touch the patient, even if...
Well, I do touch the patient.
But if you wouldn't touch the patient, would the globus go away?
It's an interesting question. I have not tried that, because I tell you what, the patient comes to me with the expectation for me to do something physical, and the treatment is always physical. I think that the globus could go away, just with the understanding. But just to make sure that they don't left with any doubts, I will do the relaxation, the manual therapy, for them to leave the clinic without the symptom.
Just for my interest, let's say you have a typical globus patient, you know that there's a psychological issue, but you wouldn't talk to your patient and just do your manual therapy. Would that also heal the globus, or do you always have to have both axes?
The good scenario, let's say the insurance for success is to understand the circumstances and to support what you and your patient understand with a bit of manual therapy. That's the best. Now let's say that we could not extract the circumstances, and then I work on the assumption that the patient is anxious, because if it wasn't found, something is going on there. If I don't have the understanding of the circumstances, after the manual therapy, there will be a moment maybe of no sensation of globus. The globus is not felt now. I will tell the patient, look, if I manage to relax it, it means that it's just muscle tightness. Maybe we don't know why you did it in the first place. Sometimes when you take the anxiety element, that people don't understand what it is, that sometimes is the cure. Sometimes patient might ask to come again, just for reassurance. In the second session, you say, you know what, I was thinking about it, and after I relaxed and I'm not anxious, I remember now when it happened.
Can you think about that you train your patient to do these manual, you do it by yourself?
Yes. First of all, if it's an irritable larynx, I will definitely explain to the patient that it's self-inflicting and they have to stop the throat clearing, and I show them how, by drinking a bit of water, and if they really have some schleim, I will encourage them to cough. I teach them how to cough. Not a violent cough, but a hissing out, like blowing the problem
Why don't
out.
you show us?
A strong airflow. And if they need to cough, I will teach them to do the airflow first and to the noisy closure after, something like that. So it's basically coughing with an open or the soft onset. And if they feel the need to clear, I will encourage them to swallow. Swallow, stop the need to do the business. And it's so important. If they can get rid of the throat clearing, it's a very good prognosis. Sometimes not easy. And I prove to them that there is nothing to clear. So when a patient comes to me with a throat clearing, the first thing I ask them is to show me what they try to clear. And I said to them, look, if anything comes between your vocal folds, it's not from above down, it's only from the lungs up. So let's see.
So there's nothing like postnasal drip that you
It's
believe in?
it's an invented symptom, and it doesn't make any physiological sense, because everything that comes to the breathing tract will trigger a violent cough. Postnasal drip goes straight into the pharynx, into the esophagus. Nothing from above goes to the larynx in an intact neurological larynx. That's by definition. That's why I'm not a great believer in acid reflux as such an enemy, because I have many issues, but we leave it if you don't want to touch it. But if something does come between the vocal folds, it's from below up. So I say
Below means from
the lungs
trachea,
up,
from the lungs, and not from the stomach.
via the ciliary escalator. That's physiology. So I ask the patient, show me what you try to clear up. I will ask them to do that. And I said, do it stronger. And I said, what comes up? Eyes widen. I don't know. What do you clear then? And then I explained to them that, you know, the throat clearing is very violent. Your clinic made a very nice high-speed video, and I sometimes, if I have time, I will show them the violence of throat clearing. And then in the session, they would not clear anymore. And I also treat them, and when I do the manual therapy, I relax the larynx anyway. And in the end of the session said, what didn't happen throughout the session? And they will think, I haven't cleared my throat. So that is the best scenario, really. And then, of course, they will swallow every time, because that will suppress the need to clear. And if they don't do it, let's say for 3-4 days, irritation goes away, and that's the end of the story.
I remember that you once told me, when somebody does the manipulation and the patient starts to get too much pain or coughs or throat clears, just like an emergency sign, that you might have been too strong, that you might have done too much to the muscles. Is that right?
No.
No.
No, but if, let's say, I touch the floor of the mouth and the patient begins to gag or begins suddenly to cough, you know that you're dealing with irritable throat, because it's pathognomonic. I mean, there is no reason why a patient will cough with a light touch. And it's interestingly enough, there is a point around the superior horns of the thyroid that sometimes patients really cough violently. And I think it's the system is hypersensitive because of some irritation.
So there are 4 things that you always tell your patients after your session.
And before. I do before I touch a patient, apart from asking their permission, although they come to me and they know what to expect, I always respect the patient and ask permission to touch them. And then I said, look, after the session you might feel a bit of ache because I stretch the muscles, it will disappear. You may feel a little bit of mucus, saliva, because when I work at the floor of the mouth, I trigger, I stimulate the salivary glands. Patient might feel very emotional and very tired. And I warn them twice in the session, before I start and before they leave.
So let's talk a little bit about the physiological rationale and osteopathy. So how long does it take for muscles to decompensate and cause problems for the patients?
First of all, I think the symptoms take a long time to develop in the musculoskeletal system, because there is a lot of redundancy in muscle activity. That's why the circumstances of the onset are very important. Let's say that you're a normative person, you only talk once a day, 5 o'clock in the afternoon, and there is also recovery. There is always some chronic tension in time. Let's say that you increase your voice load. You were an actor, and for years you are okay because vocal requirements are maybe 3 shows a week. And suddenly you got a job in the West End, and you have 8 shows a week plus singing in middle age. Then the system cannot take it anymore, and that will be the point, what we call a breakdown in compensation. Actor increase the workload while the recovery time from physical activity gets slower. And that's the point where people develop symptoms.
Are all muscles that hurt subject to stereotypic repetitive strain injury?
Well, it's interesting. We don't really know why a chronically contracted muscle is more susceptible to pain when you press on it. And I think that when it comes symptomatic in terms of pain, I think we can call it repetitive strain. which I think is probably some form of chronic inflammation at the insertion of the muscle to the bone or to the cartilage. We don't really know.
Let us talk about the posture as an important cause for voice problems.
I challenged this concept many years ago in terms of the clinical importance of posture and voice. What I mean by that, if a patient, let's say a singer, comes in the morning without a voice, would posture be the first focus of my thinking? And no, it's not, because posture is a long-term habit. We did a research, and posture has some impact on the position of the lines in the midline, and that would be related to maybe scoliosis or torso rotation. Head position has some effect on the laryngeal suspensory system, but not more than that. Posture does not affect pitch. Posture does not affect resonance. Posture clinically is not as important as people used to think, and the important thing about voice production is locally. It's laryngeal function.
At any rate, why does osteopathy work? And how many sessions does a well-treated patient need to get rid of his or her problems?
There are two questions really. The first, how osteopathy works, nobody knows. I mean, that's the honest answer, but we speculate. We think that when you took a muscle that needs to contract and to relax, and if it never relaxes fully, just by restoring physiology, when you stretch a muscle, then you probably improve its function. So that's one rationale. We sometimes think that maybe manipulation will change the hydro characteristic of a muscle. You change the consistency of the fluid inside. We also tend to think about it improving the blood supply and lymphatic drainage. So we think that the mechanical treatment has some local effect, but I think from my experience with the response to treatment, that laryngeal manipulation, when it's done well, it interferes with neuromuscular pattern. What I mean by that is that if I take, let's say, a larynx which sits high and goes with high pitch configuration, when I lower the larynx, the first reaction, the patient doesn't know how to swallow for a split second, because we change something in the position of the larynx without the brain being part of the action. So I think that manipulation has some central impact because it breaks into an existing neuromuscular pattern and it changes something fundamental. So I think that manual therapy has some impact on neuromuscular pattern in addition to local effect. I wish I had the money to do research on that, but I think that's quite important to understand the power of manual therapy, which for this explanation, it's a passive therapy, where the patient doesn't do anything muscularly and you do something on them.
If muscles are overly strained and tense, could you imagine that injections of lidocaine or botulinum toxin could be good alternatives to osteopathy?
Well, it's almost a philosophical question of two very different healing approaches. The medical approach is to seek the symptom and to deal with it. So yes, I guess that if you put a Botox, a muscle, it will relax the muscle. If you put lidocaine, it will take the pain away. But it's not going to do anything to the function. And if you think that the symptom is only an indication that something in the function is not right, it doesn't touch the function. It's only touch the symptom. And this is a very big philosophical difference between medical thinking, which is binary. You either look for finding or you don't find it. And if you don't find it, you don't deal with the function, you just try to kill the symptom. From a complementary way of thinking, you try to find the etiology. How did the patient develop the symptoms, and to reverse the reasons for that. So you don't really deal with the symptom directly, you deal with the reason for the symptom.
How much does an osteopathic therapy effect rely on a talented or skilled examiner?
Very much. But it's like in medicine, you have better palpation skills. You also ask me about how many sessions a patient needs. So if the patient has self-awareness, and if they are motivated, if it is a professional voice user, they might respond in one session. If you have a good understanding why they develop the symptoms in the first place, a good understanding plus a good physical session will be enough. So maybe one session. My average is between 1 and 2 sessions for motivated patients. People who come for more, I will challenge my own diagnosis and maybe I miss something. Because physical therapy is very direct, and if the diagnosis is right, it should respond immediately. The patient comes to me and says, Jacob, there is no change, I will check my own diagnosis and maybe I miss something.
Our approach to patient care is mostly based on shared decision-making, which basically implies that the patient roughly understands how things work. Is this also the case in your reality of patient care?
Very much, yeah. I believe that the patient needs to understand, the patient needs to be aware of the mechanism, they need to understand how they develop the symptoms in the first place, and the fact that they might be the driver of the machine that is now faulty, and we will fix the machine, but the driver needs to understand how not to overdrive it. So yes.
Can you tell us a little bit more about patient personalities and how you approach different people in terms of osteopathy?
That's more of my psychological understanding. I'll give you an example. A singer that comes to my clinic, and the first thing they do, they go and look anatomical chart. I know that they are over-occupied. The anatomy, I will share them less with anatomical explanations, because I think they are over-focusing on something which might not be completely relevant to them. So yes, I will be sensitive to what the patient needs and whether they are displacing, let's say, anxiety into overlooking for the reason. So it all depends on what I pick up on the patient's anxieties and what I think will be a piece of information that will be useful, and maybe some information is not useful. I will give you an example. On a video, you find a tiny bleed on a vocal fold. Should you show it to the patient or not? Because the bleed may be completely negligible, but when they see the picture, it becomes a big issue. So what you say to the patient and not is, I think, is a function of what they're going to do with the information. It's quite important what I share, and I never lie to the patient. Maybe we should not communicate them to the patient.
Are psychosomatic disorders frequent?
When you say psychosomatic, it already implies something which is wrong. I tend to think about on a timeline when one side is completely organic, the other side is completely psychological, and I think behind every function that affects the musculoskeletal system, there is also an element of tension. Some people are more tense than others. Some people are more, let's say, frightened. That means that the body is always a bit on the tension side. So I don't think about it as a psychosomatic because that means something pathological, but I tend to think about the contribution of the mind into a hyperfunction picture. And when I take history, I try to have a good assessment of how much psychological aspect pushing the symptom to become communicated. If you have, let's say, pain, one patient will come to the clinic and the other one just learn to live with it.
You worked in London at one of the biggest voice clinics. Can you briefly tell us what you found to be advantages when working in such an environment?
Well, it's fantastic to work in a multidisciplinary environment because everybody shares their own knowledge. I think it's quite important for me to know what the surgeon does and what the speech therapy does and what the singing teacher does. Then I know what I can contribute and what they contribute to the patient diagnosis and the treatment. Likewise, my colleagues know what I can do. So the referral becomes much more efficient because you know to refer the patient to the best approach within the team. So mutual respect, mutual knowledge. Since I started going with my surgeons to operating theater, I understand how things work. I know what are my limitations. I know when to refer, and vice versa.
In general, are there any personal or institutional factors that impede multidisciplinary work?
Yes. First of all, the idea that a multidisciplinary should be mutually respected, like what I would call eye-level hierarchy. But that's not easy to achieve. And many hospitals will have this, the doctor is top of the pyramid, although the surgeon maybe have 20% of the workload, and not every patient needs surgery. So if the system is being controlled by medical thinking, it's much more difficult to provide holistic treatment. So everything has to be either acid reflux, a diagnosis of a symptom, rather than to say, look, it's not a surgical, so it's not my job. We have a speech therapist or an osteopath or a psychologist, so it's important that nobody takes over, because otherwise it limits the way of thinking within the team. So that's one issue. Of course, crossing boundaries. Everybody needs to know what their job, and not suddenly to talk on the surgeon behalf or the speech therapist behalf. Of course, there are ego issues. There is jealousy, because maybe one treatment at some time have better success than others, so it will evoke a jealousy, or people would not give respect to the contribution of others, and they might steal ideas. So yeah, but this is human nature.
What is the role of a surgeon, of an SLP, a singing pedagogue, an osteopath, and a psychotherapist in such a team?
Well, that's a good question, because I think voice problems almost universally are multifactorial. Even if you find an organic lesion on the vocal fold that needs diagnosis and treatment, of course this is the role of the surgeon. But what do you do if there is a found pathology on the vocal fold, but you have to make a clinical decision? Should it go to surgery immediately, or can we help the patient without surgery? So the role of the surgeon find whether there is a lesion of the vocal folds or not, or whether there are any other pathologies like surrounded cancer, things that medics are trained to do very well. Then the speech therapist needs to know what she can contribute and her limitation, and she does what I call the equivalent to CBT, cognitive behavior therapy, like vocalization, change in vocal habits. The osteopath may speed up the process by direct therapy to relax whatever needs to relax and to improve function. And the singing teacher should work with the singers once they are ready to learn the stuff. And of course, the psychologist should deal with major emotional issues that can interfere with the rest of the teamwork. So everybody has a very clear role in the team.
Many patients are referred to us with a diagnosis of MTD. Any thoughts about this? And should we stick to the term, or is there anything we should change?
MTD, muscle tension dysphonia, means historically, I don't know what's going on, it's probably something to do with muscle tension. For an osteopath, muscle tension is hard, but it's not good enough, because it has to be very specific. You really need to say where is the tension, which parts of the laryngeal functions don't work because of muscle tension. Historically, because speech therapists, logopedics, worked with speech development, when ear, nose and throat specialists didn't know what's going on and they could not find any vocal fold pathology, they will shift the patients to the speech therapist. So they faced a situation whereby there is a voice problem, there is no vocal fold pathology, and there is still a complaint. So they started calling it muscle tension dysphonia for no better term, but they didn't have any knowledge of what muscle tension means. Osteopaths, physical therapists know a lot about muscle tension. I can describe to you what tension in a muscle means, area to work with, but they don't know anything about the voice. So you have two health systems. One doesn't know anything about muscle tension but knows a lot about voice, and one that knows a lot about muscle tension but they don't know anything about voice. And so those systems run in parallel, And I think the best way is to marry them. So speech therapists and osteopaths know more about each other knowledge, and maybe to combine the approach for voice problems by dealing specifically with so-called umbrella muscle tension.
SLPs are trained to treat MTD and have many techniques on how to do this. Why should there be a need for osteopathic treatment?
Speech therapists need the participation of the patient, because mainly what they do is to try to change a habit by introducing exercises, by bringing to awareness what the patient needs to achieve. So if the patient doesn't participate, the treatment is very limited or not successful. In physical therapy, when you direct your treatment to the muscles and to the parts of the laryngeal mechanism that do not function very well, it's a direct treatment, it's very fast, and the results are immediate. So as long as I can do manual therapy on a larynx, the results are straight there. While speech therapists may need 12 sessions because they rely on the patient's ability. Osteopathy, the speed of the treatment and success relies on the skill of the therapist.
Which factors can contribute to a so-called difficult patient?
Difficult patients come in all sorts of forms, from a patient who is ambivalent to treatment. Then it can be a patient that might have difficult physicalities, so it's not possible to do manual therapy on them. So that's one group. And then you have the difficult patient whereby there is some psychological system that interferes with the treatment. For instance, if a patient comes and says, I will do anything to get better, you know this is a bad prognosis, because what the patient means, they mean I will go from one practitioner to another because I will find somebody who will be able to take the problem away. That means that the patient is not aware that they themselves contribute to the formation of the symptom. So this is one scenario. There are some patients who believe that the symptom can be found by somebody. So they go from one practitioner to another because they believe that they know what's going on, but they will find a doctor that will confirm what they think they know. So this is another situation whereby it's not possible to help the patient. Some patients resist to change. They resist the idea that they contribute to the problem. They have no awareness, they have no kinesthetic feedback. Some people can be even in a dissociation state of mind, whereby whatever you do to them, they don't feel it. So you can work on a patient and say, I don't feel any change. So psychology is quite an important factor in the formation of what we would call a difficult patient. I think it's our responsibility, it's our failure to miss those.
Are there other psychological factors?
If there is some, what I would call a psychological injury, something that is beyond the patient awareness, sometimes you can see a singer who became very upset because the conductor didn't say good morning to them. Being oversensitive, that can interfere. Sometimes suddenly there is a crack in the voice in the middle of a performance, and that crack can destroy the confidence. So it's very much dependent on personalities and some psychological background that might make difficult to approach the patient in a straightforward way. And you really need to understand more about what caused the problem in the first place.
So let us talk very briefly on some of the underlying psychological factors that may interfere with successful patient treatment. When a patient says, I would do anything, what can we imply from such a statement?
Well, I explained that before, that the patient really doesn't want to take any responsibility, but there are many factors. For instance, the patient is very dependent and very suggestible, so he will go from one practitioner to another, and whatever professional will tell them, they believe in it. So they will go to one and say, you have acid reflux. So they go the acid reflux, they have no judgment over what they are being told. Another one will tell them to do something which might even not make any sense to the patient, but they will go along with it. So the dependent patient who really believes that the cue will come from outside, will go from one to another, and they will get so much information. They will be so confused. So this is another scenario. There are patients who really do not believe that anybody understands them. So whatever they say, they feel rejected. A patient that feels that to hide any psychological background because he's frightened that the people will tell them it's all in your mind, and they will be rejected and nobody wants to treat them. And they have to invent sometimes a physical symptom, which is cry for help, for a psychological distress. So these are the factors that can interfere. Now, gross denial mechanism, patient that we share together that did not remember that his father died with a voice problem. He forgotten about it. There are very powerful psychological mechanisms that can interfere with treatment.
And how about idealizing the therapist?
That's again a terrible thing, because the other side of the idealization is what we call rubbishing. The patient comes to you with high expectation because he idealizes you. And the danger is that if they don't get the immediate result that they expected, they lose faith in the therapist, and suddenly the therapist becomes nothing. So from idealization, immediately they lose faith and you are nothing. And that's no good, both sides. So you really want to create a realistic environment to be able to help this type of idealizing patients.
How about rejection and care?
There is a problem, because if you have symptoms and you go to a doctor who is not trained in that, and the doctor doesn't find anything, he makes the patient feel that it's all in the mind, and the patient feels rejected. As a therapist of the whole person, you have to be sensitive to the danger of patient feeling rejected. And so even if they come to you and they tell you a story that doesn't make any physiological sense, you really need to understand what they try to say, because otherwise everybody will push them just for the reason that they don't know what's going on with the patient, and then it becomes the patient's fault. But in fact, it's our job to understand the patient and to make sense of their complaint.
If therapists make contradictory statements about how to proceed with therapy strategies, any remarks on this problem?
So if the patient they are suggestible, so they believe everybody, and they become more and more confused. And different therapists will have different ideas, and then the patient is really lost in so much information. So somebody has to help the patient to sort out really the good from the bad.
How can we identify if a patient does not want to or is unable to work with us?
Well, you can, at least in my profession, I can judge from body language. Let's say if I approach a patient to try to examine them, and I can feel a little bit of a retreat, like they will move away from me. I know there is something. Or when I try to start manual therapy and they move away and say, ouch, before I touch them. Body language is very important. The body never lies. So the body tells you the story, really. When you take history, you know if the patient took the initiative to come to you, or he only came to you because he was referred. The patient that came to us, she was told that maybe injection will help her, but maybe she should try something before. And she started going from one therapist to another, but she did not believe that any of those treatments will help her, because in her mind she remembered that injection will cure her, but she also believed that she had to go through all the therapists in order to get the injection. So she's compliant, she's doing what she told, but it doesn't take her belief that what she really needs is waiting for her.
Other signs of conflict?
Conflict is a situation of tension. Now, if you have a psychic conflict and you don't process it in a mental way, you somatize it. Globus is a very nice example. But let's say that we have a teacher who taught for 30 years, and now she's beginning to get tired and she wants a way out. She wants a way out, but she still has 10 years before she retires. Maybe she will develop a voice problem just because of that, because she wants a way out, which would not punish her, let's say, by taking her pension away or something like that. So this is what I mean by psychic conflict. And sometimes you can identify it when you take history, and if there is a psychic conflict, then that should be verbalized and understood before we take on board any further treatment. And psychic conflict, which is not diagnosed, can interfere with treatment, and it's another example of the difficult patient.